Hopefully you've all been awake and paying attention. Those two talks were remarkable. It is rare that we save somebody's life. As spine surgeons, we make people better. We make their lives better. Rarely do we save their lives. Vertebral artery injuries, one time you may save somebody's life. Be ready. And what is happening here? This is another time you may save somebody's life. Understanding how to manage, evaluate, and manage a potential airway complication after an anterior cervical operation. So here's a guy with a left C7 radiculopathy. I wish Harrop was here because cervical radiculopathy surgery is great surgery. We make people better. I don't know what Harrop, I got a microaggression yesterday about, but some people don't get better with non-operative treatment. Actually, it's even better if you make them better with non-operative treatment because they think you're really great and smart and they're going to send their family members to see you. So if you make them better with non-operative, great. But some people don't get better. This guy had horrible triceps weakness despite 6 weeks. So anyway, cervical radicular surgery is great surgery. They won't wait 3 months, as we talked about. If they're going to chew their arm off because it hurts so bad, they're going to see like the worst spine surgeon, or not even a spine. They'll see a chiropractor, right? So be able to see cervical radiculopathy. Anyway, left C7 radiculopathy. Operation went great, less than an hour. He went home. We haven't really talked about sort of protocols on outpatient cervical surgery, but on my phone is their telephone number, just automatically now with the EMR, it comes on my phone. So on my way home, I just call my patients who I've operated on the front of their neck. At the end of the day, I just want to hear them talk. If I hear them talking and talking normal, I'm good. If they're not talking normal, that's not good, right? But I like to be able to sleep at night. I just want to hear them talk. So he did great, but my nurse tells me that he called 3 days later, and she couldn't hear him on the phone. He was struggling talking. So she came. So this is 3 days post-op with a clear retropharyngeal hematoma, and he was struggling. Now, you don't need to get x-rays or CT. You don't need to do anything. This is clearly a retropharyngeal hematoma. You can see it, and especially if what I look for, are they drooling out of their mouth? If they're drooling out of their mouth, this is a bad thing. If they're not drooling, they're actually able to handle their own saliva, and it's probably not that bad. But if they're drooling out of their mouth, that's not a good thing. But just in case you wanted to get it, this clearly, is an interesting, and CT scans are. What happens with this retropharyngeal hematoma? It is sometimes absolutely impossible to do a standard endotracheal intubation because the larynx is way over off to the side. No matter how good you are or your anesthesiologist is, you may not be able to intubate them. So unfortunately, people can die from this. That guy did okay. Actually, I took him right back to the operating room, again, 3 days, found really nothing. Usually don't. It's a little venous ooze from the venous plexus that's on the medial aspect of the longus coli. That's why it's the first thing I do when I do these operations is take a bovie to the medial aspect of longus coli, because that's where, if you're going to have a problem down the road, that's where the bleeding comes from. And he did fine. But some people don't do fine. And I'm going to tell you two stories. One is tragic, and one is very uplifting. Tragic story. I was asked to review a case earlier this year. Senior spine surgeon. I'm not going to tell you where he's from, but great guy. Senior spine surgeon. Did a 3-level ACDF. Patient stayed in the hospital overnight. Unclear. The fellow saw him in the morning. Seemed to be doing okay. But the short story is, by the afternoon, he clearly was having issues with what was everyone knew was a retropharyngeal hematoma. Went to the operating room. The surgeon told the anesthesiologist, "May be hard. I may need to may need to take the hematoma out before you can get him intubated." Anesthesiologist, "I can intubate, and I'm really good." Okay, great. She tries. Well, she tries again. 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 Before she tried, he was satting at 98%. After her fifth or sixth try, and they were struggling, the surgeon says, hold on, I'm going to open the incision, which is correct. We're going to talk about this algorithm in just a minute. But she still couldn't try. She still couldn't intubate. She tried, she tried, she tried. It was clear to them that this patient needed a cricothyroidotomy. Unfortunately, this surgeon and the anesthesiologist didn't know how to do it. They called the emergency room to get an emergency room doctor to come to the operating room to do a cricothyroidotomy. By the time he got there, they were doing chest compressions on the patient. Finally, the ER guy did a cricothyroidotomy. Patient died 4 days later from anoxic brain injury. We came up with this algorithm a number of years ago because that is a tragic problem. So, no strikeouts. You get 2 strikes. You don't get a 3rd strike. You attempt an intubation, allow them one time only. That's the best chance they're going to get. That's the best chance. After that, the chance that they're going to get is very low. You give them one chance, and then if they don't get it, you open or you teach your staff, teach your anesthesiologist, whoever, just open it no matter where you are. You sweep, you put your finger down to the plate. You have to get through the platysma, get to the plate, sweep it out. You give them one more shot. If they don't get it that time, you go straight to a cricothyroidotomy. And we're going to talk about that in just a moment. Wellington Sue helped us. We published this about half a decade ago, so it's in the Yellow Journal. But where it really is in the CSRS website, one of the most popularly viewed video. How many of you guys have seen this? I think we asked everyone to watch this, right? Thank you for watching this, because I don't like to stand here and watch me do, okay? Thank you for watching that, so now we can do more fun things. Thank you for watching that. And what was so great, what's so great about this course and why I told you this is the best course, what you heard, some master surgeons you just heard talk about their tricks, pearls, right? And you're gonna go to the cadaver lab in just a minute, and you're gonna look at the vertebral artery, you're going to expose it from the front, from the back. You absolutely need that. And all of you are going to do a cricothyroidotomy, all right, on the cadavers here. Now, here's the problem. I'll tell you what the fundamental problem is. How many of you know what's in your crash cart at your hospital and how to do a cricothyroidotomy? Do any of you know what's in your crash cart? You have no idea, right? You have no idea what's in your crash cart. Why should you? Most crash carts, I tell you, in our facility here, when you open up the crash cart and you ask for the cricothyroidotomy, you said, this is what you get. And in all of the tax-exempt hospital here, now this may be different where you are, but go find it, go look at it. Because, I'll tell you why. This is made for internal medicine doctors to do percutaneous cricothyroidotomies in an ICU. And when you open this up, this is nonsense. This is absolute nonsense. As a surgeon, this is nonsense. The first time I opened this, like, what am I going to do with this? Look at this nonsense. I don't know what to do with this or this. You need 2 things in here, and you actually have to put them together: a cannula and a trocar. All right. You need to get the cannula and trocar, and you need to put them together. All right. You need to do this. But if you're freaking out and your patient is asphyxiating and dying, this may be concerning for you, right? Do this now. Do this before you are in this situation. And there's a little knife in here, right? So, yeah, you need it. So, knife and this. But all of you, when you go home, go to your crash cart. Now, the nurse say, I have to break the lock. Well, I don't care. Or have your staff, right? Go get tell them, open up the gosh darn crash cart and see what's in there, all right? And make sure you know what's in there. But you're going to do it here. Now, so here I told you I was going to tell you an uplifting story. Earlier this year, I got a letter from a young spine surgeon who was sitting right here, our first course that we did here. He said, thank you for saving my patient's life, and thank you for saving my career. He said, he did an anterior cervical operation, was in the recovery room. Patient had a retropharyngeal hematoma. Anesthesiologist couldn't intubate him. He, right there, slept. Still, anesthesiologist couldn't do it. He did a cricothyroidotomy, saved the patient's life, and it saved his career. Because he said, I don't think I could have gone on for my career if my patient died. Now, what's interesting, just a little story. A chief resident from Northwestern did a senior elective with me. Out of high school, he went in the Army, was an Army Ranger, was a medic in the Army for the Rangers, was in Fallujah one of the first months he was there. Their Humvee got blown up. He's upside down with 50 caliber rounds going over his head. His buddy has 2 legs blown off, horrible chest, and in an austere environment, he did a cricothyroidotomy and saved his buddy's life. But as he told me, Army Rangers, they don't train them to do intubations. They go straight to a cricothyroidotomy because it's reliable. You can do it in an austere environment anywhere, and our Army they're smart about it, right? Learn how to do a cricothyroidotomy. Learn how to do it. You may save somebody's life. Thanks so much for your time and attention.